So as you know, session name is heavy metal. From anchors and screw, we'll go to something really heavy, more orthopedic rather than arthroscopy. So this was a patient. Dr. Maheshi also was following this patient, so he knows everything about it. She's a mother-in-law of an orthopedic surgeon from AIMS. So kind of a VIP, 72-year-old lady. Had a restriction of movement for 5 years, bilateral shoulder cuff arthropathy. I'll not go into detail because it is not about RSA. So 1.5 years ago, we did a cemented RSA. Patient was happy. She came 7 months afterwards for the second one. So this was the second RSA. So she had a trivial trauma after 9 weeks. And this was the thing. She had a fracture from the humerus, a periprosthetic fracture. So ARS question 1.
So Vikas, yeah. So this was uncemented, the left
This
one?
was, left one was uncemented.
The right one was cemented.
Right one was cemented, different companies,
Yeah,
different
systems.
companies. So this was uncemented, and
when-
she had a trivial trauma. Like she said, just she was
And
trying
when-
to break her fall.
And when did this happen? How many
9
days
weeks.
after?
9 weeks after.
9 weeks after the surgery.
Yeah.
Okay.
So the ARS question is: was it an intra-articular fracture, a traumatic fracture, or infection, loosening, leading to a fracture?
Can you please show the image again for everyone? The
Because we only have one X-ray post-op. This one.
Yeah.
We don't have the other view.
We don't have the other view. This was just taken in the.
the one with the
Right.
fracture, please. Yeah.
So, the lot of opinions. What we see from this is our immediate post-op. This is when she came. You can see a fracture line here. It's a more like a whole anterior cortex is taken over. So it was doubtful. You can see the gap. I'll not say loosening because of the fracture. It appears that there is a space all around the prosthesis. So what is the house opinion?
So can
Whether
I,
it is a traumatic, intraoperative?
Yes.
can
Dr.
I,
Mahesh.
every,
Have the next slide.
No. Back to the presentation, ARS2.
No, not ARS2. Just next slide. So at the same time, she was complaining of the pain on the right side also. This is almost 9 months, around 9 months after the surgery. She was complaining scapular pain, and there was a mild fracture here. If anyone can appreciate this kind of a fracture. So debate was there whether it is intra-articular. I agree with Dr. Maheshri. Most of the early fractures, maybe we initiate, especially whenever we are doing a cementless kind of a thing, when we want to do a press fit, or in this case we try to do a good press fit. We put in the head graft also to get a good fixation. It could have initiated in this thing, but she had a fracture here also. So again, as you know, she was connected, lot of opinions were coming, lot of things. So for the house, what should have been done? Like, or should I continue with the classification? I'll not go through the classification, but if we go through the classification, there is a loosening, there is a fracture, and there is a fracture on the glenoid also. So ARS question 2, whether we do fixation with the circulage via tape, whether we use a plate, or should we revise with the cemented prosthesis, revise with the long stem, revise with the tumor prosthesis. More than half are saying revise with the cemented prosthesis. So 4 is okay. Revise with the long stem. Okay.
Yes.
Vivek.
No one is for 5, sorry, thank you.
I-
It scared
No,
me.
because
Dr.
just for the
Vikas-
technical side, when you did your surgery on the left side, when you had to put in the humeral stem, this was the smallest one?
This was the smallest one, 6. Okay, smallest is 5 in arthritis. 5 is a monoblock. I didn't
Yeah.
want to put a monoblock, so I used the 6.
6. So,
This is the smallest one.
and this is the smallest one. So people are talking about long stem. That's the reason why I'm asking you the question. Because if you want a long stem, you need a long stem 6, which may not go into the distal part there, because the canal is very narrow. Okay, that's one thing. Second thing, when you had to put it in, how much of reaming or rasping had to be done? Was it easy going in?
Easy, easy.
Easy
Because
one.
we were planning cementless, so we were easy on it. Only thing with retrospect, I put a bone graft so that.
Posteriorly?
Yeah.
Was
Bone
it put
graft
posteriorly?
intramedullary.
Intramedullary?
Yeah,
Because that
so that-
sometimes pushes the
Yeah.
fragment backwards,
Yeah.
yes.
Okay. Antonio?
But I think that with long stem is good, but you need also a cerclage for this part, because
Yeah.
only long stem you risk that you lose the fracture.
Okay.
Any particular reason for using a different implants on the both the shoulder?
Yeah, first one was.
Evolutis, I think.
We, reason was, first one is evolutors. We had few complication of doing a glenosphere when it's a spiral blade. So we wanted to change from spiral blade to the locking screw.
Okay.
Can I just comment on the first X-ray, that the other side? Actually, you've done a very good job. That alignment is good. That fracture at the bottom you see is not because of you, because all the forces which go in your spiral blade are central. They are not peripheral.
No, this
So-
was same time. That was other cases. Actually, we had few complications.
No, before, no, even this
last
one,
7-8 months.
you don't need to worry about it, because that's
No,
not the
that's
load
what we have
taking
left.
part of it.
This is
So,
just a.
so that's why I don't think spiral blade had an issue in that sense.
No, other case like spiral blade, as yesterday also someone, sometimes, sclerotic bone, when
Sclerotic
you're
bone,
hitting on a spiral blade, it does fractures.
I normally drill it and then do it, because if you have very hard bone, that's how you do.
Yes. Kapil? What did you do?
So, again, as Kapil said, we reduce the fracture. This is, I'm holding with the tape. So I found that it is not loose once you're reducing the fracture, because duration is not much, it's 9 weeks. So we can reduce it, and there's some amount of lucency you can see around the processes at the tip. So we use a cerclage tape, and after the tape, after the tension, you can see that even that lucency reduced. So we could reduce the fracture completely. So that was the thing, but not comfortable living like that. So we use a periprosthetic plate from the hip side, which comes with the circlage wire. I didn't use on the lateral side. I use it on the anterior medial side, because here I didn't have to erase any soft tissues. I could just put a plate, open it, just put a plate, because it was already reduced, and we could pass 2 circlage wires in these 2 holes, then 1 locking screw proximally and 3 distally. So that was a fixation. That is 2 months after post-operative, but I didn't dare to do the post-op therapy. Still, patient is doing whatever she's doing actively, but she had a osteoporosis, so teriparatite. This is the other side, so that's a result of other side. But here the restriction is there on the other side. This is the fractured. Sorry. How to start this? Okay, here only 90 degrees of forward flexion. Here she could do full. These videos were sent by the patient, so I don't know whether it's playing. So this is where glenoid fracture. So we didn't do anything for the glenoid. Only thing I wanted to say like we started her treatment for osteoporosis, and that was done. Teriparatide was started so that healing could have been there. So this is only this much amount of forward flexion, but with therapy, I think we should get it better. So classification, there are many classifications, but Kirchhoff classification, which is widely used, in which they say if there is a acromion fracture, either fix it or you can leave conservative. Glenoid, if it is a fracture is going up to the base, revise it. Otherwise, we can conserve, but most of the cases they advise revision, but our case was undisplaced, so we didn't do anything. It was conservatively treated. And the thing was immediate, or you can say early fractures. The loosening is not an issue, so we should try to treat them just like a fracture, and they do well. So should teriparatide be started prophylactic
Vikas.
after RSA?
Okay.
Sorry,
No, we can go ahead with this and then we can.
we can have discussion.
So, in the immediate post-op, we saw that there was, the bone was quite weak on the metaphyseal side, on the left side. So you think that you could have added some bone graft along with the fixation?
Retrospectively,
No,
I say,
it has worked well. It has worked well,
see,
but
it is the view. Other
Yeah.
view, it is there. Lateral cortex was intact. If I can, okay. First we answer. So going through the literature, there is no evidence of starting teriparatide after RSA. Only evidence I could find if there is a tuberosity fracture, it helps in healing of a tuberosity fracture in RSA. But otherwise, even in cementless knee, etc., there are some studies, but there is no definite evidence that we should give prophylactic teriparatide. Yeah. So we'll go to the. See, in this view, you're saying that there's no, but one of the views, there was a good amount of bone. Maybe there's a change, but cortex was intact. Cortex was completely intact. That's what we can see in our post-op also. You can see continuity of the cortex.
Yeah.
It's very thin, and that is one other thing I would like to discuss. How many of us are using cementless arthritis?
cemented arthrex or
Cementless. Because
Yes, mostly cementless.
Actually,
arthritis, because arthritis we found that stem is little bit broader, and transaction wise it's rectangular, and
because I am skeptical about using Arthrex in ladies, Indian ladies especially, because
yes,
the
that's what I
size,
found.
component size are much bigger.
Much
So
big, much
you
bigger.
could use them
Stem
in
is
men.
much bigger.
You could use it in men, but ladies you should be very careful.
So I'm using the same implant, and do you use the old version of the stem or the new version? Because there's the Universe 3 and the next one. Because the stem is very hooked and very
okay.
crowded at the beginning, but now they made it round. So it's
No, this is round. Previously, actually,
okay.
previously it was completely rectangle.
Exactly.
Now they have removed the edges,
Yeah.
but size is same. That
Yeah. So then, so now they have a 5 as well. But what kind of metaphysis size? Which tray? did
six.
you use?
This was 6.
No, like 36, 39, 42. Which one did you use? The tray. The metaclean. Which? So you have.
Glenna said no. Base plate.
Metaglean.
So the, yeah. So
Humeral
the
side it is 6. Like we have only one.
No. So you have this diameter of the glenosphere, and the tray. What is the?
It was 36, I think. 36.
Okay,
36.
That's the smallest one.
Smallest one.
When I'm looking at the thing, that if it's a very aggressive reamer that they have, so you get left with an empty shell if you have a small patient. So what I tend to do is I use it as an onlay system. So it's an inlay.
This is
Yeah, but if you just with a cups elevator or with a nibbler or whatever remove the bone in the metaphysis and undersize it in the diaphysis, you get your proximal fixation, and you get less bone resorption. But if you look at even after 9 weeks, you get like the whole cortex is very thin. And I'm looking at my results right now from the last couple of years, and even after a year, I see no stress healing at all. And in the beginning, I was getting also the stems a bit bigger because I wanted to have good fixation. So you see that happening very fast. So and when the bone thins, you get a fracture much easier. And when you need to do a revision, if you have a fracture, I mean, if you have to revise the stem, you get an enormous amount of bone loss. So undersizing the stem and get your proximal fixation in this implant is very important.
In this implant, maybe one size less, but that was a monoblock, no modularity.
That's
so
even better because then you have no friction. I have a lot monoblock, and it's compatible with the 36.
yeah, that's
that would be the best
retrospectively.
Yeah.
With due respect to Dr. Vikas Gupta sir and to all the senior surgeons here, so should we make it a routine to treat osteoporosis before going in for these elective surgeries? Why not we give teriparatide for 3 months pre-op, and we can avoid these?
Yeah, that is that's what we can treat osteoporosis, but it's after something happens, then only we become wiser.
You may
But
start treatment for
We do it
osteoporosis.
in
But-
knee
but-
also. If the patient is very osteoporotic, she
But
needs a TKI.
Literature doesn't say anything about.
Literature doesn't say, but I think
3 months wouldn't do any magic.
You-
Just to clarify, 3 months is no cutoff
3
date.
months is no cutoff, but
Like-
definitely
like-
it helps, sir.
No,
we
that's
are-
more in the mind.
The DEXA remains the same even
Uh,
after 2 years of teriparatide in most of the patients in India, particularly females.
In the same, this thing, I had a patient with severe osteoporosis who was due for TKR, but when I saw the DEXA, it was -3, 2.4 and all. I said, we will not do the TKR now, let us wait and give teriparatide. She was not willing for teriparatide, but she took this thing, denosumab. And after 2-3 doses, we went in and we got a DEXA before that. And it was still showing -3.4 and all. But intraoperatively, the bone was good.
So
See,
one word of caution for
Again,
you.
that
Need
would
not
be
go by
One word of caution for people we have been on denosumab, because the bone becomes very hard and when you're hitting it
becomes very
cracks.
hard, yeah.
So
Sometimes
it
it's
cracks.
difficult to
So
put
you
the
have
screw
more
in.
fracture chances if you have had
Yeah.
denosumab before. One. Second thing, with your teriparatide, the amount of bone building which happens is about 20% over a period of 1.5 years. So it will not change in 3 months. So there is no point giving it in 3 months. If you want to protect it, you do the joint replacement, load the bone becomes stronger. Because bone doesn't become stronger with an injection. The load makes it
Yeah,
stronger.
definitely.
So point taken. So
Yeah.
so basically osteoporosis has to be treated along with the surgery.
Sir, one point which is I
Yeah.
can make. Sir, what you're saying is very true because it is basically in affected shoulders. It is not loading, no activation, muscle activation is not there. So definitely this is going to be osteopenic or osteoporotic. There's no way of knowing or predicting.
Just so actually BMD was done. BMD was done. It was osteoporotic,
Right, sir.
but that was after the fracture.
Yes, sir. So BMD, which part was done, sir?
Hip.
Exactly.
Standard hip,
I would
spine
like
and
to emphasize that. So there is no relation between a generalized BMD of the hip and the spine to a proximal humerus BMD because proximal humerus BMD is not available. So we had uploaded a paper right now on measuring osteoporosis using HU units on CT scans. So that is, it is a very simple technique to do, and I think that is what we should try to practice, to try to pick up. So just have to draw a circle if you are doing the entire proximal humerus. So draw a circle around it on a CT scan on a particular software. Your HU units are going to come out. So we know the average Indian HU units, which is equivalent to a T-score kind of thing. That can predict us, and we can be careful in those cases.
But are nomograms available? Because we have to compare with something like.
Yes. So we have in this paper, which we are coming out, we have measured a control group of normal HU units for average healthy young Indian population. So that you can definitely compare to an abnormal. So we know this is 40 is normal, and if this is going to be like 20, definitely that is there. So my take was there's no connection between a generalized BMT and a proximal humerus BMT. That because that is pathologic, and HU units is a very good technique to do it. Sir.
So for the sake of time, we'll have one last comment from
Yeah.
Dr. Pratap.
I completely agree with what Ayyappan said. And an extension of what Deepti said, we should be a bit careful about using denosumab, because usually we give it for six doses for three years, and once you stop it, there's an increased chance of risk of fracture.
because-
And that is where the periprosthetic fractures after 3 years happens, and once you got a windshielding effect and all sort of things. That is where you are going to have an increased chance of a periprosthetic fracture. So you should be, either you should be prepared to take it for lifelong, or you should be able to do something about that. Yeah.
Thank you. Thank you, Dr. Vikas, for presenting the case. Thank you so much.